afternoon and welcome. We had a bumpy start. I don't know if maybe some of you would have known that, or maybe you're just tuning in and you have no idea what we just went through. But I want to welcome you. My name is Judy, Gabriel, Virgo, and I'm here on behalf of Black Mental Health Canada. And I want to welcome our second guest of our podcast in recognition of Black Mental Health Week, Dr. Crystal Clark. Welcome and thank you so much for hanging in there with us.
Yeah, my pleasure. It's a pleasure to be here. Looking forward to the conversation, and we're gonna make the best of it. Okay.
Yes, we will. We shall. We shall.
Mhm.
So I'm gonna like quickly move us through because I think once we get into the discussion and really know, Dr. Clark, where you're coming from and the work that you
Mhm.
do, it'll make up for the bit of a disaster. Okay. So,
Okay.
so I'll just quickly say that I am, as I have mentioned before, workshop speaker facilitator with Black
Mhm.
Mental Health Canada. And as part of, in recognizing Black Mental Health Week this week, we are launching this week of podcasts, talking with people who are, movers, shakers, trailblazers in the area of Black mental health. And
Mhm.
so I'm going to give a bit of a bio, and then I'm going to do like a rapid fire to kind of really ground us in our discussion today. So, Dr. Clark is an associate professor in the Department of Psychiatry at the University of Toronto. She's also a scientist at Women's College Research Institute and will serve as the associate head of research at Women's College Hospital. As an adult psychiatrist, Dr. Clark specializes in mood and anxiety disorders and is internationally recognized for her expertise in the treatment of women's mental health across the reproductive lifespan. So, from menstruation to pregnancy to postpartum, infertility, trauma related to reproduction, the whole gamut, the whole spectrum. Dr. Clark is a researcher who aims to optimize mental health treatment for pregnant and postpartum people from all backgrounds, and much of her research has focused on pharmacology, management, and establishing of dosing guidelines. That's really really key for bipolar disorder during pregnancy and postpartum. And I'm just giving you a snippet, and as we talk, you will definitely get a bit more of what you're doing. What I did like very much, though, is that your research aims at addressing the significant gaps in the field of psychiatry, the characterization of experiences, risks, and optimal treatment approaches for paramental health among Black and Indigenous people of color. So thank you and welcome again.
Yeah, thanks for having me.
So rapid fire.
Okay, I'm trying to brace myself.
Okay, Canada.
Oh, the behind.
Behind. Yeah,
I'm sorry.
that's
I'm the first time.
that's why I like this. Okay, and I'll give a bit of context to that. So you were just here just shy of 11 months, or about 11, or shy of 14 months in Canada.
14 months, yes.
A lot of your study was done in the States. You were based in Chicago, and
Hmm.
so I welcome my word welcome. Your word is behind. Okay, I love. Okay, psychiatry.
Needed.
Okay, Black women.
Um, you know, First I was beautiful and yeah, just beautiful.
Okay, and then
Hmm.
the last one, mental health.
Underrated.
I love that. Okay. So that kind of leads me into my first question, underrated and Black women beautiful and needed. And what what made you have this focus in your career? This
Yeah.
specific focus.
So you know, just to be honest, I did not start off in Black mental health. Always has been an interest, but I navigating the what I call the ivory towers did not make that interest easy to focus on. So but it's always been something I've been doing kind of on the side, so to speak. Um, and over time, what I appreciated, not only just being a psychiatrist and how, when I say needed, it's like, over the years we've dealt with so much stigma around mental health and this idea across all populations that, it's kind of like, what is it really? People act like it's some kind of voodoo or something. It's like, no,
Mm,
it's
yeah.
actually biological illnesses that we're dealing with.
Mhm.
But what I was noticing even more as I dealt with my Black community is that, the stigma was even higher amongst us, especially amongst Black women, where the need to be the strong Black woman, to be, in control, to fight through, to push through. Mental health was going so neglected, and I found myself thinking, there's no way I will continue my career as a Black woman and not
Mm,
find a way to make impact for Black women. So I set out to do that, finding different ways to see where I could have an influence and really impress upon the community that this is needed, that we are beautiful people and we can still be beautiful and strong and address our mental health and any other um, illnesses we're dealing with physically. No one thinks they're weak because they have a cold or the flu or
right,
um,
right.
any other condition. It always comes back to mental, where we start to feel like, oh, I can't talk about that, I can't address that, and so coming up here.
Mm.
When I say behind, I thought the U.S. was behind. To be honest, behind comes up because when I got here, I was thinking I came in with a very like, oh, Canada's progressive. They know what they're doing. They have got this down better than the U.S. does.
Mm,
And what I found was that actually there are definitely some things that I love that Canadians do, and that the system, the government is doing differently than other places such as the US. But when it comes to Black health,
mm,
especially Black mental health and Black women's mental health, it's behind in ways that I was surprised to see, especially when we just start with the basics of there not being race-based data. So you can't even can't even quantify it.
that's right.
So I'm learning anecdotally from my patients and from the community and from those with lived experience that, this is, this is an issue. There are disparities, or at least there are perceived disparities amongst the community. But now we need to put some data, some statistics behind it to better understand, so that we can figure out, well, what exactly are the gaps in Canada, not in the U.S., where
Mhm.
Canada cites often, or not in the U.K.,
That's
where
right.
Canada also cites often, but in this unique population of beautiful, Black, heterogeneous, it's like so many different cultures and backgrounds and roots in the Black community in Canada, especially in Toronto. And that's a unique community, and we need to understand what's going on.
Hmm. Absolutely. And I don't know what that is. I don't know if that plays into, because we hear this a lot. And as we're doing our workshops and presentations and gathering data to make it meaningful to our Canadian audiences, you're right, there's none there. And when I, implore some organizations to start collecting data, you're at a particular important place in your intakes, in your assessments to start collecting data. It's like, oh no, we they feel very uncomfortable. And I don't know if that stems from this being nice, Canadian nice. You don't want to ask those questions. It may seem intrusive, but it's really critical to be able to have that information to do a proper analysis of what the need is. So yeah,
Mm-hmm.
that definitely is a problem that we're seeing. What were some of the, or I shouldn't say it like this, were there any resistance? Like you talked about the stigma of Black mental health, especially among Black women. And, we have this attachment around being resilient, and we understand that has layers of what that means.
Mm-hmm.
Is Are there any specific sort of resistance that you may have had in kind of carving out your space and doing this, saying, look, mental health is really important, we need to talk about it, we need to address it? I think we've come a long way, but in your work, has there been any particular roadblocks or difficulties?
Yes, there've been plenty,
Okay.
systemic as well as from the community.
Mm,
So systemically, when I go to get grant funding or something, there's a lot of bias there, for the people who are actually sitting at the table, the reviewers who are actually considering whether this is worth funding. And so there are
mm,
questions about, well, why not everyone? you know, kind of that all lives matter argument, or why not Asians and indigenous people, which absolutely need more research too. And I don't minimize that at all, but but there are differences. And I, as a Black woman, would not feel comfortable going into another community that I don't understand culturally, or even come close to understanding culturally, and saying, "Hey, I'm going to research you." I would happily partner with my Asian or Indigenous colleague, but I definitely think that deserves someone who's from the community being involved. So you get questions like that, and just a lot of like pushback on trying to understand the importance of it, and a lot of that pushback comes from, in my experience, from bias and lack of understanding. And unfortunately, I think it's not even conscious. Sometimes it's
Mm.
unconscious bias of,
Yeah.
stereotypes that have just been kind of ingrained in people. And it's like, oh, is that an issue?
Mhm.
Then you come to a land where it's like, no, I mean, we're good. We're not, we don't have those types of problems. We're progressive up here. Whereas I see the lack of looking at race as a way to perpetuate disparities, actually. It
Absolutely.
perpetuates anti-black racism. So I don't see it as oh, we're being nice. I actually see it as a form of further
Mm.
oppression, and especially coming from the U.S. and our history, it's hard for me to see that in a good light.
Mhm.
So on the flip side, though, honestly, the community in my engagement, because it was very important to me to understand what the community felt, because I don't want to bring my bias from the
Mhm.
U.S. and impose that on anybody. So I
Mhm.
really was listening to the community organizations as well as patients saying, well, what's been your experience in mental health, perinatal mental health? Do you guys, have resources you feel comfortable with, this and that? And it kept coming up that there's no race-based data. We need more data. We need more data to push funding and policies in terms of the organizations. And I was surprised, honestly, early on, like, what are we talking about? And people sharing their encounters with racism, and I'm like, really? I honestly, as a coming from the U.S., I'm like, nah, it can't be as bad. It just is no way. It can't be, And people are like, let me help you understand. So, yeah, but with that said, there also, I think there's some grappling with, well, how to do it, and
Mhm.
how do we get those, although the organizations are very much invested and there are some people who live and experience invested, there
Right.
are a lot of people who are kind of like scared, a little fearful of what that means in terms of, well, will people take my kids away if I
Mm.
admit to having depression when I have a
Mhm.
child? And this is something I dealt with in the States too. There's the fear of there being some consequence of
Right.
acknowledging mental health.
Right.
Religion has played a heavy role, I
Mm.
feel, across geographical locations in which
Mhm.
the idea is to pray it away, or
Mhm.
this is like considered some different ailment from
Yeah.
a broken leg or a heart condition. It's like,
Right.
yeah, just be strong, and if you just pray on it, it'll be okay. And I'm
Absolutely.
constantly telling people the brain is no different than any other organ; it needs
Mm.
treatment. And
Mhm.
prayer is more about um, finding the vessel that's going to help you, that God is working through to help you get better, and not so much ignoring uh,
Right.
the ailments.
Right. Well, that's a really key shift and a really important way to say that. And I think that that could be, kind of empowering or liberating, if you will, for some people to hear that, because I think a part of it is they really don't know. There's a lot of ignorance around it. They don't know what to do with it. And so that's why
Mhm.
the education piece is so important. And
Yeah.
then being able to encompass the other parts that people have held on to. Yes, there's value there, but it really needs to have this approach where, as we, the term holistic approach, right? Really
Yeah.
looking at
Yeah.
this in a holistic fashion. Absolutely. So I'm going to get to some of the findings, I guess, in the work that you've done, because
Mhm.
so for me, coming from a social work perspective, community mental health sector, it really is about it's a reactive approach, right? We're sort of dealing
Mhm.
with what we're seeing in society, helping people manage through, and referring, linking, supporting, all those sort of things. Your work, how I see it, is kind of getting to the crux of the issue, of the problem.
Mhm.
And so, especially being in Canada, really thankful that
Mhm.
you're here, where you can now give us some really good facts of and scientific and evidence, really, to support the things that we need to do, sort of on the front lines. And so, has there been anything staggering so far that you have found out, like in your research, particularly when you're looking at the gaps, in that reproductive cycle of Black
Mhm.
women and our counterparts? What are some of the things that have stood out for you in that work?
Yeah. So some of the things just, and I'm gonna start kind of where I was in the U.S. and looking at the fact that Black women have rates of postpartum depression, for instance, double to triple that of their white counterparts.
Mm,
That in the past decade, the rates of suicide have increased such that they are highest amongst Black birthing people compared to any other racialized
mm,
group or white population. And that data, as I've continued to, look at that and research, like what's going on here.
yeah.
Some of where I've been seeing gaps are that often data is not capturing the heterogeneous population. So
Mm,
we're either looking at all low income,
yes.
uneducated, like I almost feel like it's caricatures of the Black population or something.
Yeah. Yeah.
Um, and coming up with these conclusions, or rarely are we looking at the opposite, the maybe middle class, as we would call it in the U.S.,
Hmm.
or just not accounting for the social determinants of health, I guess, is the best way I could put it, and really comparing apples to apples, oranges to oranges, what's going on, and really focusing on our community. We don't need to normalize whiteness as the
Hmm.
comparator. We don't need to say, um, well, it's not normal or it's abnormal because it's not. This is not how it happens to them. We need to
Right.
understand what's happening to us. So those are major gaps globally. It's not. I don't
Mm,
know that anyone has, to my knowledge, it hasn't been done in the U.S., the U.K., or any other developed country, and it definitely hasn't been done here in Canada.
mhm.
Uh, Gaps in Canada are huge. Like there's so far, as I'm researching, we're just trying to do some basic stuff like where's the data? And we've
Mm.
only been so far able to find
Two studies.
kid you not. And so it's
Yeah.
such a dearth of information that I've working with my team to go back, like, okay, we
Mhm.
gotta be missing something.
Right.
Let's scour, like scour the earth to make sure, because I don't want to miss anyone's published work as it relates to Black perinatal mental health in Canada, particularly in the Ontario province. Though is what I'm specifically interested in because the Black population is larger.
Right.
But two studies, and they're not looking at psychiatric diagnoses across pregnancy and postpartum. Healthcare utilization, suicide rates, yeah, I mean, I can go on and on. There's just no data that I've been able to find so far. And so, if anyone's listening and knows of some data, please send it to me. Send me the articles. But so there's huge gaps. I mean, with two studies, I'm pretty much. I feel like I'm pioneering and just trying to start somewhere and better understanding between qualitative interviews, so interviewing people about their experiences, but also currently looking to tap into the databases where race has been captured, and
Mhm.
like one database in Canada that is connected to birth and birth outcomes, and trying to see what foundational data we can pull from that and what gaps we learn from that to further guide us in terms of, okay, well, let's explore if suicide rates are high, for instance, but like, well, how do we explore prevention of suicide in the Black community,
Mhm.
education, educational series and things like that.
Mhm. So it's really as I'm hearing this, and you're talking about, the again, the data just being almost non-existent, two studies, what really stands out for me there is that, well, that means our stories are sort of non even existent, right? Like we're not being heard, we're not being considered, we're not
That's
even there.
right. And that's what I'm saying. Anything like to be that invisible is
Yeah.
not like nice. That's yeah, that's not helpful.
Yeah, yeah, absolutely. Not helpful at all. And so who do you ally with, or sort of partner with, in order to start, firstly understanding that getting this data is really important, and then who do you see right now as current players in your sort of scan? I know that you're fairly new here. In
Yeah.
your scan of Canada or Toronto, who do you see as those allies to potentially get that information from, or at least to start doing that work?
Yeah, yeah. Well, I have definitely spent the past year just doing that, trying to
Mm,
understand the community, and
yeah,
I have spoken with well over 20 different organizations. I learn from my patients all the time,
yeah,
and been seeking out those with lived experience. And I'll shout out to a few that
please.
for me, there's so many great organizations. I feel like the community space is phenomenal here in terms of all the work people are doing. But what I've learned is that there's a lot of siloing.
Yeah,
There's a lot of people doing great work in their own silos. I would love to see more collaboration. And but Black Mental Health Canada is one of the people groups I've been learning from. Um, Ancestral Hands Midwives group.
mhm,
They're another wonderful group. Birthmark, Mino Care, uh, um, Women's. I'm blanking on the name. Women's Health and
women's hands.
yeah, helping.
Yeah,
Yeah, say it again. Women's Health and Helping Hands. Yeah.
yeah,
So yeah, those I always twist up the it's like a tongue twister for me,
yeah.
but yeah, those groups, and I highlight them specifically because they are groups, organizations that are serving the Black community, but also addressing mental health, and also, you know, for in some cases addressing perinatal mental health specifically in Black
Mm,
women. So I'm learning a lot from them. And Healing Sister Circle, that is a group of therapists, Black female therapists,
mm.
and yeah, so it's been so many people I've met and continue to stay connected with, and have asked them to participate in being um, panelists in just being a collaborative or coalition, so to speak, as I embark on this research, because it's very important to me that as we learn things, that we bring it back to the community leaders and patients with lived experience to say,
Mm.
how would you interpret this data? Does this line up? Because we want to make sure that anything we publish and put out there, that it is actually helping the community and guiding, kind of guiding next steps. And for anyone that's outside of the community, that they're able to use that hopefully to provide more culturally sensitive and culturally based care.
So, Dr. Clark, you're really doing some foundation work. You're really kind of starting from the beginning here.
Yeah, I very much feel that way.
And I'm glad to hear those organizations that are on board and that are willing to sort of do that work with you. And
Yeah,
so, yeah, I mean, it's unfortunate, but we're here. At least we're
yeah,
here. It
yeah,
is 2024, but and this is also the thing that, when people sort of say, like, why are you harping on this, or why are you still talking about this? Why does race matter? Why does it, like, we're in
yeah,
2024 things? This is exactly why, right? Is
yeah,
because without it, there's no understanding. We're invisible, as you've mentioned, and then we really can't make progressions in terms of really being able to identify specific issues that impact us, as Black people and Black women,
yeah.
and so forth. So I just have something I wanted to share with you. And I'm just going to switch a little bit, and then I'm curious about around the medication studies that you've done around bipolar. But so a
Mhm.
bit of an anecdotal kind of story is that when I was having children, here. Again, born in Canada, born in Toronto, born and raised here, had my children here. And I, by choice, sought out a midwife and was going to have home birth and so forth, and thought that
Mhm.
was, a more natural way of doing things.
Yeah.
My and only now coming to realize that younger women who are having children are doing that as a method of necessity. They don't feel safe to go into
Mhm.
hospital.
Mhm.
My niece now, I've got lots of family in the States, and they were like, that no, that's something we do, that we've been doing that. We don't feel safe going into the hospital. And I'm starting to hear that narrative now here. Any comments or thoughts around that,
Mhm.
in terms of what that looked like in the States and why potentially it's happening here now, I guess?
Yeah, I'm that word behind comes comes
Okay, all right. This is our
to
theme.
mind.
This is our theme.
um, yes, so what I'm hearing from
Hmm.
patients with lived experience or persons with lived experience is that similar to what I hear in the States, is that they go in, they feel unheard, unseen, their complaints not addressed,
Hmm.
and so they feel like, there no one's paying attention, no one believes me, no one is really paying attention to what I've been through. I had a patient recently share that she had a pregnancy loss,
Yeah.
and being younger at the time, although married and responsible, everyone knows about failed birth control. Um, she was dismissed and berated by the physicians and told that she should have been more careful, and
Mm.
but no one addressed the fact that that loss was significant for her,
Right.
and that it actually, she just had failed birth control. Actually, she wasn't the stereotype that they had painted her as, like, oh, you're just this young woman who's out here wild and not responsible, sleeping around. I mean, like all the things,
Yeah.
and that was what she felt,
Yeah.
and there was no just no empathy. And so, what does that make her do when the next time something happens?
Mm.
She's less inclined to
Yeah.
want to deal with really someone that doesn't look like her.
Right.
That's what I consistently hear from our
Yeah.
Black community, is that they're seeking midwives, but partly seeking midwives that also look like them, and seeking care elsewhere from providers that represent or look like them.
Mhm.
And this has been big in the U.S. for a while. I mean, we've really been highlighting those stories more. I think the stories are very present here. We just aren't. They're not writing about them and
Yes.
putting them on the news as much. But
Yes.
um, but I mean, we hear when you think about um, the different celebrities that have spoken out about not being heard and almost dying in childbirth.
Mm.
Um, and yeah, like Serena Williams being a perfect,
Yeah.
tennis player.
Right.
Um, Perfect example. She had to fight, even despite her resources, had to fight and say, "Hey, something's not right." She had a pulmonary embolism. I mean, she could have died,
Yes.
and it would have been simply because she said, "I'm in, something's wrong," and no one checked it out.
Right.
Without race-based data, we have no idea how often that is happening
Oh,
here.
yes.
So so
Yeah.
so definitely something I think is so needed to look at. What are the outcomes, even unrelated to mental health, just pregnancy outcomes? How many mortalities?
Hmm.
There's an answer there as to, okay, is this the normal amount? There are definitely complications that happen that are just unpredictable, unanticipated, and sometimes take someone's life, and the doctors can't do anything about it. But when you start seeing
Yeah.
significant disparities,
Yeah.
a lot of times we're seeing either a Black women have some complications that we have yet to try to prevent. Um, but it's hard to say that there's not some bias in there in which patients just aren't listened to. They're not believed. They're saying something's wrong. I'll give one more example. A woman at the CDC who was researching Black maternal morbidity and mortality.
Mm.
uh, during pregnancy and postpartum, she died. She had researching it. She was one of
Wow.
the major researchers, and this hit our news cycle some years ago. And basically, she had gone. She had said she wasn't feeling well. Doctor dismissed her. Her family was like, "Go back." She said, "I went back. Nothing. Still wasn't feeling well. Something seemed off. Blood pressure was still high." And her family kept urging her to go back again, but she wouldn't because she was like, "Well, I've gone back twice.
Right.
They keep telling
Right.
me nothing's wrong." And she
Yes.
died within 6 months of having her child. I forget the exact timing, but it was definitely within
Right.
6 months of having her newborn baby. So those stories are becoming more public or have become more public in the U.S. I
Mhm.
just think they're lacking a platform here.
Yeah. Yeah. It just makes me think how deep, this systemic racism really goes, right? The roots
Mhm.
are really, really deep, and then yeah, it's really disparaging actually to see that. So I'm looking at our time, and I want to shift a little bit, if you don't mind, to just some of your research around bipolar disorder and during pregnancy and postpartum, and
Yeah.
what that looks like, and what some of your should I say, treatment recommendations, or what you've sort of collated so far?
Yeah, yeah. Happy to talk about bipolar disorder as well, which I will say is definitely an area where we are not diagnosed enough,
Yeah,
period.
yeah,
So we don't
okay.
even have the stats on like how many Black people, men or women,
Mm,
who have bipolar disorder. What's the percentage? We don't really know.
yeah.
But globally, the reason this has been an area of intentional research for me is because I
Mm,
also feel that the bipolar disorder community is marginalized within psychiatry. So it's another marginalized population. And when I was in training, I would have patients who have bipolar disorder, and we're treating them, and they're still sick. And I was like, "What is happening here?
mm,
How can it be that I'm treating this patient and they're still having episodes of depression or mania or just not feeling well?" So, well, go ahead.
so I'm sorry, just so I'm
Mhm.
making sure I'm following. So you were treating them for bipolar, and
Mhm.
you weren't finding much efficacy. Okay.
Right. So, not
Okay.
finding much efficacy in pregnancy. Now, prior
Okay.
to it might have been fine, but
Right.
in pregnancy, all of a sudden they're unraveling.
Right.
So I found myself wondering, well, how do we prevent that from happening?
Hmm.
Because when we think about treatments and we think about the illness, we're thinking about two different exposures to the unborn fetus, right?
Hmm.
So we always worry about, oh, well, medication is so bad, and that's going to cause the baby to have some type of malformation or
Hmm.
developmental delay or something. But we don't often think about how the illness actually is actually more likely to cause poor outcomes to the
Hmm.
pregnancy as well as to
Right.
the fetus as well as to the infant.
Right.
So as I got to understand that a little bit more, I was like, well, more often than not, the medication is actually helping the baby, the mom. If mom is well, baby is well.
Yeah.
So, how do we prevent recurrence of illness? How do we maintain wellness in patients with bipolar disorder during pregnancy and postpartum? So, I set out on this journey to better understand medication management. What do we need to do? And so, what I learned in my research thus far is that the medications we use to treat bipolar disorder are often diluted in pregnancy. A lot
Okay.
more volume,
Yeah.
metabolism, and these particular drugs respond, the metabolism is greater because of the physiological changes of pregnancy, because of that volume increase, because
Hmm.
of the increased metabolism of these particular drugs, and therefore they lose efficacy. So when I think back to when I was training, I'm like, well, gosh, they basically had nothing on board. That's why I wasn't working. It was therapeutic failure. So
Okay.
um, and this is definitely a complicated story, but the basics are that we need to dose medication according to the physiological changes that the patient is
Hmm.
experiencing in pregnancy. So often that means higher doses. Doesn't mean that those higher doses are going to be more detrimental. Just
Hmm.
means that higher doses may be needed to be therapeutically effective.
Mhm.
And I talk all over the world about this particular, my findings because
Right.
so often during pregnancy with any disorder, but definitely with bipolar disorder, where it's even more risky, your general psychiatrist will stop all the medications. Oh, we should stay on this in pregnancy.
Yeah.
Or they'll go down in dose. And I'm like,
Right.
oh my gosh, why you have the patient on the medication if you're going to go down in dose? But then you go out to the primary care world where, a lot of family practitioners are treating these illnesses, and many
Mhm.
of them may not know this. So, on, you know, they're not intending to undertreat, but that's
Mhm.
what's happening.
Mhm.
So
Mhm.
my goal is to develop guidelines that will hopefully become universal one day, where it's not just the perinatal experts who are like, oh yeah, well this is how we should do this, but it's more of a standard of care because
Yes, a best practice.
yeah, it shouldn't be that the patient with bipolar disorder who's pregnant can get a doctor who's like, well, I mean, stop the medication or
Right.
stop, or let me, decrease the dose or never change the dose.
Mhm.
And just watching them get sicker and sicker and saying, oh, well, it's just pregnancy, a result of the
Mhm.
pregnancy.
Mm.
Yeah.
So that's actually a really fantastic finding, and it's going to shift because, like you said, you're up against sort of
Mm-hmm.
this thought that okay, it's pregnancy, it's lower the medication or no medication in
Mm-hmm.
order to, but this is actually kind of turning that on its head a little bit.
Mm-hmm.
But of course, there's research to back that up and better
Yeah.
outcomes and so forth. So yeah, it's now about making that to be the best practice, right?
Yes.
For people who are, yeah, that's pretty important. That's pretty pivotal,
Yeah.
actually.
Yeah.
Yeah,
No, definitely continue to be excited about that too.
yeah,
And it's been very rewarding because it's an
absolutely.
illness that affects all walks of life, all racial backgrounds, and I've had all racial backgrounds that have come to get treatment from me, and it's been so rewarding to use these strategies that I've learned through my
Mm,
research and have them do well.
mm,
It's not 100% foolproof
of
by
course.
any stretch, but so many have done better, and they'll tell me, "Oh my gosh, this is better than how my last pregnancy went," or
Mhm.
I've never felt as good, and I was so scared I didn't think I could have a child having bipolar
Wow.
disorder. Um, I have patients that still reach out, whether they find me on Instagram or Facebook and tell me, I had another child. Thank you
Wow.
so much. So it's
Yeah.
been extremely rewarding work to really help people during that time.
Absolutely. And then it really attacks the whole stigma around this as well, right? As you're talking about.
Yes.
So it's very freeing, right?
Yes. No, I had a family come in, mom with the patient. She was just like, I can't believe you're saying she can have this child with bipolar disorder. And I was like, why not? you know, and she stayed well. We adjusted that medication and she stayed
Okay.
well and ended up having two children. And
Oh, look at that. So I was going to ask you that. So you did mention that you adjusted the medication. So after the pregnancy, obviously there's a review, evaluation, the medications may be tweaked too.
yeah, absolutely. Yeah, got to
Okay.
go back down. Got to go back
Okay.
down.
Okay. Well, that's wonderful. And I think too, like I'm wondering because again, this is not related to paramate natal care, women who are in childbirth, but there is this sense around one of the mistakes that have been made, particularly with Black people who have
Yeah.
psychiatric illnesses, that they've been over medicated, and that's one of the
Hmm.
problems. And then so the response to that is, okay, let's just take them off medication because there's really that lack of trust to feel that they're going to be well taken care of and the medication will be prescribed in a manner that really is able to treat them effectively. Any
Yeah.
thoughts around that? I know it's kind of just dipping into another area a little bit, but any thoughts around sort of that sense of being
Yeah.
over medicated?
Oh, plenty of thoughts around that.
Okay.
It goes back to, and I've seen this over my career.
Yeah.
It goes back to culturally sensitive approaches,
Okay.
but also removing the bias,
Hmm.
as well as systemic structures that are like, well, you can't afford, the higher price
Mm,
medication. So we're
yeah.
going to give you what's available that you can afford. And some often that is not the newer drug, not the drug that causes less side effects. You know, there's less thought around, oh, this is going to really knock you out, or this is
Mm,
going to cause weight gain, or,
mm-hmm,
less education around those things. But also, and this is my own theory, I can't say that anyone has written about this. This is my
mm-hmm,
anecdotal experience
mm-hmm,
that there's overdosing sometimes, so you have a black man,
mm-hmm.
right?
Yep,
He's tall,
yep,
um, you know, may weigh more or whatever, then it's like, oh,
yep,
he's gonna need higher dosing. Well, there, it's not necessarily a like weight
right,
correlation with some of these drugs or height correlation, um, but I will see people be, dosed as if there is
yeah,
some type of correlation.
yeah,
I feel like if we were universally listening to our patients,
mm-hmm,
then we would approach dosing differently. So when I'm working with a black patient who most of mine are also kind of like, yeah, I don't know about medication.
right,
We we talk through that at length, and I
mm-hmm,
am in support of them taking however much time they need to decide if that's a choice that they want to proceed with.
mm-hmm,
But I find that there's still some paternalism out there, especially when the provider is not, maybe a black provider, where that's offensive. Why you keep coming back if you're not going to do what I told you to do?
right, right,
Whereas my approach is keep coming back. We'll keep talking about it. I'll keep educating you about it. I'll keep answering your questions. You keep sharing your experience. We'll keep dissecting this until we understand, what is working for you and not working for you. And we can try this medication. You don't have to, let me dispel these myths for you that it's going to cause you to be addicted or cause you to change your personality or just so many of the things that people share with me about their fears, and we work through those fears. And if they take a medication that isn't ideal for them, then we stop that and we try something else. And I let them know that that's kind of the process. But
mm-hmm,
I find that because there's been so much mistrust,
yeah.
there needs to be so much more education and support.
So I think that really hits the nail on the head as to why people are saying that they would rather be served or
Mhm.
supported by someone who looks like themselves, because you're going to take that time to do that because you're coming from a place of genuine empathy and understanding and lived
Yeah.
experience to a certain degree, whereas they're not able to get that from a doctor who is a white doctor, for
Yeah.
example. So it makes complete sense that this is why, and we see that as well in, when we do our workshops and so on and so forth. That is the feedback that comes back to us, is that I'd rather see somebody who looks like myself so that
Mhm.
that time and patience can happen and a trust can build up. And so that's really, really key.
Yeah. I think we need to do some type of manual or something. My white colleagues ask me this all the time, and I don't feel like these are rocket scientist types of I don't approaches per se, but I do think there is something very just being able to take the patience, educate, and support. Just that approach, I think more of the white colleagues could be received well if they genuinely feel like, okay, I can support you and
Mm.
just taking time, just talking to you. But I feel like, you know, that is not as common.
Absolutely. And so you talk about a manual, and I think that that is an excellent idea. And Black Mental Health has actually developed a manual in order to be widely shared around organizations that can respond better and do work where,
Mhm.
there's that diversity, equity, inclusion lens. And
Yeah,
so there is that manual, but we need many manuals, right? It
yeah,
looks like, right?
absolutely.
So you talked about one way of sort of your approach to being culturally competent, what I like to call it cultural safety. So provide that safe
Mhm.
space. Is there any other approach? So if we're thinking about someone like myself, frontline or one-on-one counselors, therapists, is there any other thing that you can add on to that you would say as an approach for people that we're seeing who are coming in, Black people needing mental health support?
Yeah, I think we have got to. When I think about approaches, I don't know that I have anything specific for anything different than what you guys might be doing when people come in. But I think what is needed is us broadening our
Mm,
education into the
mm,
community in spaces where people aren't coming in or thinking about mental health, but they're probably dealing with it
mhm,
because we don't want to wait. I feel like the people that come to me is because it's gotten bad.
mm.
They're not coming to me because I just wanted to check in and see. I think maybe something's wrong.
Right.
It's gotten pretty significant, not necessarily to the degree of hospitalization or something, but it is really impairing their life. And it'd be nice to catch people much sooner and give them the education and help them to understand when should you start seeking help. What
Okay.
does help look like? What should you expect to get when you seek help? Working with churches too. There are plenty of progressive churches that are starting to
Okay.
address mental health, thankfully.
Okay. Okay.
And but yeah, I definitely think this is conversation that a narrative that needs to be promoted in those spaces as well. Like, yes, mental health is important. Yes, it's okay to seek mental health care. Yes, it's okay to take medications if you need them.
Mhm,
And there's nothing wrong with that. And
mhm.
let's pray about it while you're getting your treatment.
Right. Absolutely. I love that. I love that. So it's really around broadening the
Hmm.
scope, really. And I think that that's quite powerful because it's validating as well, right? That
Yeah.
these are other aspects of the individual's life or circumstance that needs to be brought in. And really, it's a sense of
Yeah.
validating.
We
Yeah.
gotta normalize it. And
Yeah.
I think we're in a movement right now to normalize that more. The younger generations are
Mhm.
really
Yeah.
um, advocating for mental health, addressing mental health more, trying to normalize that. I think we need to all work together to do the same.
Okay. I'll touch on this just last bit before
Hmm.
I let you go, if that's okay.
Yeah.
And I will have a bit of those words too at the end, if you don't mind. It'll be easier, funner words.
Okay.
So the end of the reproductive cycle, let's kind of get to the end. So we're talking about perimenopausal, menopausal. And so up until now, again, my sort of experience of what I've heard and seen is it's white women. The face of white women hold that space. And
Hmm.
so here is your work where you are focusing on Black women in
Yeah.
that time.
Hmm.
What are some of the key things that you want to put out there?
Gosh, just
I know it's big.
I hate to depress everybody. I feel like we have no there's
Oh, I
like
know.
we have no research there either. I just
Oh,
finished working on an article with the National Institutes of Health, which we got published recently, and the whole point of that kind of deep dive with other Black colleagues out there was to try to understand what do we know about
mhm,
Black women in perimenopause
mhm,
and mental health.
mhm.
And our findings were minimal in terms of globally what studies have been done,
Right.
um, especially with, I don't know if you're aware of this, but psychosis, there's been cases of onset of psychosis during the
Mhm.
perimenopausal period.
Yeah.
And we're seeing this across all populations, but definitely in the
Mhm,
Black community. And we're trying to like, what is this? What's happening?
mhm,
What was this someone who was at risk all along, or is this new?
mhm.
And
Right.
it's harder to dissect in the Black community in some
Mhm.
ways. So we have a lot of work to do to understand what is happening, but
Yeah.
the treatments continue to the standard of care continues to be antidepressants, hormone replacement therapy, antidepressants as the first line, hormones as the second line, and I can't impress upon people enough to try other things. It's not a one size fits all. So I
Okay.
have some people who really respond to acupuncture, for instance.
Mm.
Can't stress exercise and nutrition enough. Just
Okay.
getting back to the basics here.
Yeah.
Really self care as it relates to yoga has, for instance. Although I myself, I tell my patients all the time, I have a hard time too trying to like, okay, just get my mind
Right.
quiet, be in this yoga position. But there's actually tons of data showing
Mm.
how effective it is. So
Okay.
So there's lots of things out there that are working for different people,
Okay.
but we have a lot of work to do to understand perimenopause
Mhm.
globally for anybody,
Okay.
and then you add on even
Yes.
more um, need to understand it in Black women specifically.
Okay. And then we need to talk. We need to talk to each other. I think that's
Yes,
yeah,
yes.
that's the
Mhm.
key for me is really having those conversations and talking about it with each other.
That is a key, Judy. I was involved in some. I don't know if you went to the. I'm blanking on the name of it, but there was an event here in Toronto before the new year where we were all getting together to talk about perimenopause, different generations across generations,
Okay.
and it was excellent because that's lacking. And so then you feel like something's wrong with you and you're abnormal,
Yes,
when in
exactly.
fact, actually, everyone before you's gone through this. They're like, oh, yeah, I mean,
Yeah.
yeah, that happened and that happened too. And might just knowing that it's coming be less anxiety provoking. And maybe understanding some strategies that different people have taken that helps them make you feel like, oh, I got some tools in my toolkit. So
Mhm.
talking and supporting one another is paramount.
Okay, for sure. Well, thank you so much. So one thing I want to ask is, do you plan on staying in Canada to help us?
That is the question everyone's asking me.
Oh, okay. All right.
I don't plan to go anywhere anytime soon.
Okay. All right.
Yes, I will be honest. My family and just about everybody I know is in the U.S.
Okay.
But I did see this as a opportunity to help.
Mhm.
And when I chose to come up here, it was because there seemed to be an energy and progressiveness around
Mhm.
pursuing equity at this time.
Mhm.
I'm hopeful that it stays that way, but there was definitely a lot of support for me to come here and do this work.
Mhm.
And so I was like, all right, I'll give it a try.
Okay.
And so far, the support has been really good, very consistent. There's a
Mhm.
lot of I didn't know how much work there was.
There's a lot of work.
That was eye opening, but the support has been consistent thus far, and as long as I can get that support, I want to use it to make an impact in the community, and the impact here I think will reverberate elsewhere. I think it can help the U.S., it can help the U.K. Um, because what's different here is it is a lot of pioneering and foundation
Yeah.
building,
Yeah.
and so maybe we can learn from the mistakes of the research or the gaps. So we won't say mistakes, but the gaps in the research
Right.
elsewhere, and kind of build on that here and take it back to other countries and places where Black communities need it. So I'm excited to be here and to pursue this research for as long as possible. I got to understand the economics of staying here to retirement per se, but
That's a whole other.
yeah, that's a whole nother thing. But I have no plans to go anywhere anytime soon.
Okay. Okay. Well, you know what? I personally appreciate that. And I'm sure our listeners are, and the community as well, and who you're working alongside is really appreciating that because I think, as you mentioned, it's the foundational work that needs to be done. And if it's not
Mhm.
here, then we need to start somewhere. And so I
Yeah.
think it's fantastic. And you're coming in and bringing us such a wealth of information and knowledge and the zeroing in
Mhm.
on the psychiatry of that whole reproductive, process that women go through. And I know there's other things as well, but that's really, really key and really centered. So I'm appreciating that as well.
Yeah.
So we'll do a little bit of a fire, rapid
I'm like,
fire.
I don't know if I'm great at this, Judy. I'm like, I have the thought, and then I'm like, no, don't say that.
That's what we love. That's what we love. Look, it established our theme, right? Behind.
Yeah.
So self care.
Oh, yeah, essential.
Okay.
Essential.
All right. All right. I know this is not fair, but I'm just going to ask you to say just one or two things that are essential for self care, and then I'll go on with my next word.
Yes. Boundaries.
Mm-hmm.
Making space is what comes to mind. Setting boundaries and making space for yourself, meaning
Mm-hmm.
time to take a walk, time to sit quietly, time to sleep. Making room for that.
Okay, wonderful. I love that. Thank you. Hope.
Oh, the first thought that was needed. Um, I want to say maintain hope. Yeah,
Okay.
I
Okay.
think we lose it sometimes in these fights. So maintain.
Yeah. Okay. All right. Love.
Ah, thankful for love. Yeah.
Okay, wonderful. And I'm not fair because I'm going to throw in this word, but allyship.
Oh, yeah, you're not there.
I'm sorry.
More more genuine. I don't know what one word to go with that one.
That's okay. That's okay.
More genuine allyship is needed. There's
Okay.
some beautiful allies out there, and I've been fortunate to come across some. But there are some people who think they're being allies and haven't quite done the work.
Mm,
Um,
okay.
and there's some people who have no interest in being allies.
Okay.
So,
All right. Okay. All right. And what's next for you?
yeah. What next for me? Well, hopefully I will be, sharing in a few months that I have some grant funding on
Ah,
some of
nice.
this foundational work.
Mm,
But that's really what I'm focused on right now is just
okay.
getting funding to build on, some of these ideas and see what we
Mhm.
can do to make an impact, and have many community partners out there who are, that, like I said, have been great in trying to help me in this endeavor,
Nice.
support, writing letters of support and things like that. So that's what's next. Just
Okay.
and continuing to educate. I do a good amount of speaking on Black maternal mental health as well as bipolar disorder, and you know
Mm,
I value that because it's an opportunity to educate folks and hopefully break down the walls, the mystique, the myths.
right. Right. Well, I can't thank you enough, Dr. Clark. And again, I thank you for hanging in there with the technical difficulties. I appreciate you hanging in with us. And I feel the conversation was really fruitful. And I think I got a good, or the listeners got a good, including myself, a really good idea of where you're at and where you want to set your roots in Canada and what you're bringing to us. So thank you so much for all of your time today.
Yeah, so thank you for having me. I think, yeah, it was a wonderful conversation. And I think, despite our technical difficulties, we made it work.
Oh, yes.